Good morning, Rebecca.
Hi, how are you?
Good. How are you doing today?
I'm doing well, thank you.
We've got about 30 people registered, but since this is the August meeting, it is often a smaller group. So we'll see, just since it's, the high season for so many folks who are operating programs that either have an actual like garden or growing element or just even working with, high production season. So we'll see how many folks end up showing up. Um, We've got a couple in the waiting room. Anyways, any questions for me or things to check in about before we dive in?
No questions at the moment.
Okay, cool. Yeah, Shin will not be able to be here. I know she was there for our meeting a couple weeks back. Um, but Kaylee Summers will be, I believe. So, yeah. Okay, cool. I might give it just one more minute and I'll start letting folks in.
Awesome.
Good morning, everyone. I'm letting folks in from the waiting room. And might give it just one more minute to get started. Hi, Kaylee. Good morning.
Good morning. Hi, Claire. Hi, everyone. Thanks for being here.
Okay, I'll get started with our grounding slides. Kaylee, do you want to give the OCFSN updates or would you like me to talk through those two slides?
I if you want to carry on, you go for it. Yeah.
Okay,
Thanks.
okay, cool. So please drop your name and organization in the chat, especially for questions and answers or any discussion during our guest speakers' presentations. It's always helpful to know where one another are coming from. You could also change your Zoom name if that's easy for you to add your organization next to your name. So really quickly, just a bit of grounding. So just sharing what this working group does, since we often have new folks every quarter join us, just to keep some continuity. So this group brings together people and organizations that support Veggie RX style programs in the state of Oregon. And we provide this peer learning space, which brings together nonprofits, community-based orgs, coordinated care organizations or Oregon's Medicaid managed care entities, healthcare, Oregon Health Authority, et cetera, to collaborate, bring a space for advocacy, and also shared learning. And so for this, the purposes of this group, Veggie RX is a produce prescription program that's used to treat or be a preventative service for patients. So that might be a community-supported agriculture style share or box, a card or voucher to shop at farmers markets, or participating grocery retailers. And there's probably some more models out there, but those are two examples of the programs that we have operating in the state. So today we are going to give just a couple quick updates from OCFSN and the working group. I'll just share those kind of on behalf of Shin since she's not here today. And then we've got a guest presentation from Mom's Meals and their policy team, Kimberly Satterfield and Dr. Rebecca Zuchowski. We're really excited to hear their experiences of working with health-related social needs and Medicaid systems in other states, and hear about kind of their advocacy work and what they might recommend as Oregon proceeds with our 1115 waiver, and health-related social needs nutrition benefits. So even for folks in the meeting today who are maybe not interfacing with Medicaid systems or kind of insurance healthcare at all, we hope it's still really informative and interesting for you to hear their perspective as program operators. So really quick update. The first in-person convening since I believe 2019 has been scheduled. It's going to be November 5th through 7th, 2025. So bookmark that on your calendars or save some time. It's going to be at the Salishan Coast Lodge, which I can't see my speaker's notes, but I believe that it's very close to Lincoln City on the coast of Oregon. And there is a limit on number of people from each organization who has attend just because of capacity of the space. So there'll be more details to come about that. Make sure to enroll in our Veggie RX Google, I'm going to forget the name of it, but the Google group, so you'll get updates about that. And then one more update. Yeah, go for it.
Can I interrupt really quick? If you're like really jazzed about this and maybe have some planning background, some ideas, we are still looking for folks that are interested in being part of the planning committee for that convening. So if you're interested, reach out to us or reach out to Shin and join the planning committee for that too. Or if you know somebody else in your program or your region that would be interested in that, let us know.
Cool. Thanks, Kaylee. So we also are conducting the biannual Veggie RX census. You may have seen a couple updates about that in the newsletter. And we're extending the deadline to, it's not next Monday, that's a typo, to Monday, August 25th. We've conducted the census biannually since 2019, and it really helps us understand the state, well, helps you all understand the state of Veggie RX programming in Oregon. So our steering committee, I realize I didn't introduce myself, and I don't think my name is in our Veggie RX Zoom account, but I'm Claire Londigan. I use she, her pronouns, and I'm on the steering committee for the working group. So our steering committee will look at all the data, put it together, and present it back to you so you all can see who else is doing this work in the state and what their programs look like, what the limitations are, especially as federal funding priorities and other funding may be shifting in the coming year or two. So if you do operate a Veggie RX or Food as Medicine program, please complete the survey. It really does help everyone understand things every couple years. And we'll include the link in the follow-up email from this meeting. I should pause. Any questions about this? And Kaylee, anything to add?
Not from me, but if you all have been around for previous census, you may have enjoyed seeing the results of that, and those results are really not possible unless people participate. So I see Marcy nodding her head. I remember, like looking at all that data and it's being so informative and really a connector between programs to see what other folks are doing. So if you're able to participate, if you're connected to a program or know a program in your area that might be interested that's not on the call today, please encourage them to be a part of that, because that, when people participate, it really does inform this larger picture in Oregon. Yeah, Marcy.
How do we know if we have completed it already? Because there are a lot of surveys going around right now, and I think I completed it, but I'm not sure if it's the same one that this is.
You can reach out to me, Marcy, because I've got that list, and I'm going to be reaching out to some folks individually who have participated in the past, the ones who haven't yet. So you can check in with me.
I was wondering if we should put in what we're planning to do, or if we should wait until next survey.
That's a good question. I believe that we tried to kind of structure the questions as the state of the program during the last program year. And so it's a little funny, our timing for releasing it this summer. It would have been, I think, more logical to do it in the spring, given that time period we're trying to capture. But yes, I also think that there is a question in there that is looking forward. So capture your last year's program cycle, and then any questions looking forward you can address there.
And Rose, are you with a brand new program, like you haven't had a year that you've operated?
Yeah, we're going to, so we have done 2 seasons of our Harvest Box, like collaborative CSA, and that's what we're using as the basis for a new like partnership with medical professionals, with medical offices. So we've kind of done a piece of it in the past, but we have not done a Veggie RX. So this will be a new program.
So I would say maybe my advice with that would be to put in the details of what you've done in the past, but putting like a descriptor in there that says this is moving towards a more medical model with this partnership with our clinic, to explain, like, so that it doesn't skew you. Like if we have that explanation in the data, then we can figure out like how do we place this with all of the other data from the other programs. Yeah. Thanks, Rose.
Yeah, thank you.
I have a question or two. I'm looking at the survey now. Firstly, it says to share details if capacity is in a different unit of measurement, like households rather than like households or families rather than participants. Then it doesn't actually let you put in text. It only allows numbers. So I wanted to say households or families, but I can't do that. And then the second question is, like if we are listing it, can we provide information? If we're okay with it being listed, can we provide information for like people who are interested? And I could do that. We could do that, but we're like not in a spot to just be like, oh yeah, come and sign up. So it might be like some false, misleading information. So not sure what to do there. I guess I could just, yeah.
Yeah, thanks for flagging the kind of lack of free text, it sounds like. I'll go back in and look at that. But that might be, we might just send that out as an FYI in the follow-up email here that we missed that in our review process before releasing it. We have already gotten a number of responses, so we'll look at how to make that change in a thoughtful way. As far as you definitely don't need to share if you don't want to have it kind of advertised as how people can reach you, how potential participants can reach you. I don't know, Kaylee, do you have any thoughts on how that's been done in the past?
Yeah, I will say that when people Google search their favorite search engine for Veggie prescription programs, OCFSN ends up fielding some emails about programs in different areas, including program participants or clinical partners that are interested in how they refer their patients to programs. And so a lot of programs are more like closed in the way that they recruit their participants. But if you are a program that is like anyone in my area could potentially reach out and sign up, or you're actively recruiting for folks, so that we know, like, we don't want to pass on your information to a person that really like,
right,
you're not going to take them into your program. But if you're like, yeah, happy to field those questions, or even from clinical providers who are wanting to refer patients.
Yeah.
That's kind of what we want to know. But if you're not that type of program, you don't have to give us your information to publish that.
But then will the program not be listed? I guess that's what I was wondering. I was like, I would like it to be listed, but also and could have like at least some point of contact, but or some place to send requests. But I also worry that I would get overwhelmed if like people are like, oh, I want that, I don't know whether
yeah. If you put in the field, like, would love my program to be listed as a program that operates in Oregon, but we're not able to take referrals at this time. Or
Okay,
something
great,
like that.
great.
Yeah.
Thank you. We took up way too much time with my questions. I appreciate it though. This is exciting.
This is helpful actually, because it helps us like figure out the bugs and also how people are interpreting the survey questions. So thank you for bringing those up.
Appreciate it.
Yeah. Okay, any other thoughts and questions? As Kaylee said, it is a good time. We certainly have time on our agenda today if there are other questions. All right, I'll move forward, but feel free to pop them in the chat, and maybe Kaylee, you can field those as they come in, since I have limited visibility since I'm sharing screen. So we'll move on to our guest presentation today. The policy team from Mom's Meals are joining us, as I mentioned at the very beginning, kind of intro slide. So Kimberly Satterfield, who's the Senior Policy Research Analyst, and Dr. Rebecca Zuchowski, who's a Research Policy Analyst with Mom's Meals. I'll let you two take it away and introduce your organization and yourselves a little bit more. And you can just prompt me to advance the slides whenever you're ready.
Sure, thank you. So just to give you just a brief overview about Mom's Meals. So Mom's Meals is a leading provider of fully prepared, refrigerated, home delivered meals. We've been serving clients nationwide for over 25 years. So we support seniors, individuals recovering post-discharge, members managing chronic conditions with nutrition solutions tailored to their needs and designed to meet the specific health needs and personal preferences. So our mission is rooted in compassion and personal experience, caring for our clients as we do our own family. As far as myself, I am Kimberly Satterfield. So both Rebecca and I are in the policy team within the government advocacy and fairs wing unit, whatever you want to call it, of Mom's Meals. I have been here a little over a year, but I come from I have about 16 years experience in social service administration. I was in the policy team at the Delaware Division of Medicaid and medical assistance for 10 years. And prior to that, did some time in Tulare County in California. And then Rebecca, if you want to wave, Rebecca, she joined Mom's Meals earlier this year, and also works, closely with me in working in policy, public comment, all of the areas around food as medicine, home delivered meals, HCBS, LTSS. She comes with a very large research background, spending time as a research specialist at the University of Tennessee most recently, and her work with her PhD in public health nutrition from University of Tennessee. Do you want to go on to the next slide? So just quickly, we're going to, over the next few slides, just go over some basics about the structure of the Medicaid program and some common flexibilities that states use to provide food as medicine solutions. When we met with some of the team members, I believe Kaylee and I can't say everybody's names on the screen, but we talked about some different things we might cover today, but not wanting to put way too much all in one presentation. We thought we'd focus on some of the way the Medicaid program is structured, the different flexibilities to provide this food as medicine solutions, some key terms that you may hear commonly in the space, and then the evolution of nutrition supports in Medicaid program as well as the difference in the authorities, why some programs might look different from state to state. And then just talk a little bit about getting involved in advocacy at the state and federal level, and end with just some clear calls to action. Next slide, please. So what is Medicaid? So basically, Medicaid is a jointly funded federal and state program that provides healthcare coverage primarily to low-income individuals, children, older adults, and people with disabilities. So states are actually not required to participate in the Medicaid program, although at this time they all do. But if they do participate, the federal government sets basic standards and requirements for states regarding mandatory populations and services that must be included in their Medicaid state plan. The Medicaid state plan is basically the primary contract between the state and the federal government. It's where they outline their basic general administration, eligibility rules, services, all of their basic type program development. And they also have the option to include additional populations and benefits, although those optional benefits and populations are still limited by the Code of Federal Regulations and the Social Security Act as to what can be included. So beyond that, there are Medicaid flexibilities. There are a number of Medicaid flexibilities that states can institute. For sake of this discussion, we're going to keep it to the most frequently ones, to the ones seen most frequently around the food as medicine space. And although each of these are considered flexibilities, they still each come with their own set of federal guidelines and rules that must be followed as it relates to the program development, any public input process, the CMS approval process and timelines, implementation, and then monitoring and evaluation. So the first I included here is managed care. There are a number of different ways that managed care can be approved as a flexibility, but in general, states can contract with managed care organizations to deliver Medicaid services. And this offers flexibility in how the care is delivered and financed. They can establish a managed care delivery systems that are just in specific regions, systems that have different benefits than those in managed care versus fee for service. They can implement managed care for specific populations. So there's a lot of flexibility states have in how they implement managed care within their state if they choose to do so. The next is the home and community-based services flexibilities. So home and community-based services first became available in 1983 when Congress added a new section, section 1915C, to the Social Security Act, creating the 1915C waiver. So you'll hear waiver said often with different flexibilities within Medicaid, and the term waiver applies because it's essentially doing just that. It's waiving requirements that states are required to meet within their Medicaid program. So the waiver is allowing to waive certain requirements to implement things differently. So for the 1915C waivers, it gave states the ability to waive certain federal regulations so that they could provide individuals that have institutional level of care needs services in their home and community. So as to avoid placement in institutional settings like nursing facilities, hospitals, ICFs, things like that. And these are the most common types of HCBS programs that you see out there, but there are also several state plan HCBS programs that states can implement. There are also different sections of 1915 of the Social Security Act and have their own set of rules and requirements, although they're all somewhat similar to a degree. These are the programs you're going to see that provide the traditional sets of home delivered meals and nutritional counseling, mostly for the aged and disabled, the term that's so out there, populations. For 1115 demonstration waivers, so these waivers are authorized under section 1115 of the Social Security Act and allow states to waive certain federal rules and regulations, similarly to 1915C, but these have a lot more flexibility. So the intent is to test new and innovative approaches to providing Medicaid. So the purpose is to demonstrate the effectiveness of new approaches by testing them in a controlled environment. So as such, states must carefully develop monitoring and evaluation programs to evaluate outcomes of their demonstration progress or demonstration projects to assess their impact on access, quality, cost of care, and a number of other things depending on the type of program that they are implementing within their waiver. So these demonstrations also must advance the goals of the Medicaid program and be budget neutral, among other things. So they can test new innovative things, but in doing so, they still have to be focused on advancing the goals of the Medicaid program. And then a lot of states do use their 1115 waivers to provide HCBS services, similar to those provided in 1915C. I'll say Delaware because I manage that waiver is one of them, where they develop, rather than managing a bunch of different waivers, they put all their programs within one waiver. And they'll have their LTSS, which long-term services and supports, and home and community-based services within that waiver. But CMS will develop standard terms and conditions, so rules within their waiver that align with the 1915C rules. So they're very often similar looking in how those parts of the programs operate. But 1115 waivers provide additional flexibility, such as the you see with the health-related social needs services, reentry population programs. Some of you may have seen that. A number of different things can be done under 1115. And then the next that you'll see commonly in this space is in lieu of services and settings. So in lieu of services and settings are just as they sound. They also, ILOS, you'll hear that a lot. They are alternative services or settings that are provided to a member in lieu of or as a substitute to a covered service or setting under the state Medicaid state plan. So for example, an ILOS program may provide members with chronic conditions such as diabetes or end-stage renal disease with 2 home delivered meals a day as a substitute for a possible emergency room visit or hospitalization that could happen down the road. So managed care plans historically had flexibility to provide in lieu of services, which we go back and say they have to be in lieu of services, have to be provided by managed care plans. That's part of their rules. It's not something that a fee-for-service state can implement. So the managed care plans have historically had flexibility to provide different services than those that are required under the state plan. However, CMS believed that codifying the practice and regulation would bring consistency to the plan's use of these alternatives, as well as ensure protections for members. So in 2016, CMS issued a large managed care final rule, and within that, just had a little section that they codified in CFR, just basically recognizing this for states. So then in 2024, CMS issued another final rule, and within that, they codified a very large section, very large, but a much larger than previous section for in lieu of services programs. So as a result, any state that had an existing in lieu of services program prior to 2024, such as California's Community Supports Program, were required to review and redesign just portions of their program to come into compliance. So a few key differences to keep in mind when thinking of an in lieu of service and 11 to 15 waivers, which are the two that outside of the traditional HDM are the two authorities you're going to see where there's food as medicine solutions, nutrition support solutions. Two big differences to keep in mind is that an ILOS is required to be cost effective, but they can measure cost effectiveness over time. Whereas budget neutrality within an 1115 waiver is much more stringent and applies to the current waiver period. Also, in most instances, 1115 waivers are approved for a period of 5 years, where an ILOS must go through an approval process as part of the managed care contract approval process every year. Next slide, please. So a few additional key terms. You've heard me say a couple of these already, and we'll talk about some more as we go through. They're managed care organizations, so MCOs. These are private health plans that are contracted by a state to manage and provide the Medicaid benefits. So MCOs accept a set per member per month capitation payment to manage all of the members' healthcare needs. So in this arrangement, providers contract directly with the MCO versus the state, as is done in a traditional fee-for-service structure. And as I mentioned, ILOS can only be provided under managed care contracts. And MCOs must meet specific measures around quality, medical loss ratio, access, etc. Coordinated care organizations, or CCOs, these are networks of healthcare providers, which include physical, behavioral, addiction, recovery, etc., who all agree to work together in their local communities and provide services under a Medicaid state plan. So CCOs are considered to be a type of accountable care organization, and they're accountable for access, quality, health spending, among other things. And CCOs can also be considered a type of MCO, which is the case in Oregon. I'm sure, as most of you are aware, Oregon operates under the CCO model, in which they are focused on prevention and helping members manage chronic conditions. And under this model, CCOs can provide in-loop services. Social determinants of health, that is a term that's been around a lot longer than HRSN and some of the other terms. Social determinants of health are the conditions in the environment where people are born, where they live now, learn, work, play, worship, age, etc., that affect a wide range of health, functioning, and quality of life outcomes. So if you think about social determinant of health, it refers to community level factors. What is around members in their community over their lifespan that have affected all of those things. Upstream drivers of health is a newer term, very new term, that you're going to start seeing more. This is a more comprehensive terminology that was recommended in the CMS proposed rule for calendar year 2026, the Medicare payment rule or physician fee schedule rule. People call it different things. But in that rule, CMS is recommending to replace social determinants of health with upstream drivers of health. And in that, they say that it encompasses a wider range of root causes and behaviors that impact health. So it'll include SDOH areas, but also includes patient behaviors such as poor nutrition, low physical activity, smoking, etc. And then lastly, health-related social needs, or HRSN. These are the social and economic needs that individuals experience that affect their ability to maintain health and well-being. So this such as food insecurity, stable, affordable housing, lack of transportation, etc. So health-related social needs often develop as a result of SDOH or upstream drivers of health. Next slide, please. So to kind of grow on the last few slides a little bit, just want to talk a little bit kind of about the coverage of nutrition support services within Medicaid and how it's evolved. So the coverage of HRSN within Medicaid evolved as the focus of SDOH increased. Prior to that, states only covered nutrition supports in the form of HDM, home delivered meals, as I mentioned, under HCBS, and or nutrition counseling under either state plan or HCBS authorities. However, during the COVID-19 public health emergency, there was a lot of attention brought to things like social determinants of health and health-related social needs. Prior to that, there was limited authority and focus within the Medicaid program to address these factors. However, between 2021 and 2024, CMS began to develop various guidance for states, encouraging them to address health-related social needs. And then specifically in 2022, CMS announced an 1115 waiver opportunity specifically for health-related social needs, which was followed by guidance in 2023, providing a detailed breakdown of the different authorities that could be used to address health-related social needs. And that included guidance for states on how they should devise the programs to stay within the specific authorities the state may choose between. As some of you may be aware, in 2025, that's this year, the new administration rescinded the previous HRSN guidance, but in doing so, said that they were not going to recall any of the approved 1115 waivers. However, as they come up for renewal, they will be looking at all of these waivers, and not just these programs. There's other programs types that they've done this with, designated state health programs, and a number of other different types, where they're just going to be working closely with states to review and ensure that whatever programs they have implemented really do follow and meet the goals of the Medicaid program as a whole. So as any current programs that are operating within 1115 are operating under approved STCs, which is probably a term I should have added to the terms now. You'll hear STCs when people talk about waivers. It means standard terms and conditions. And it's really the contract, the additional, I look at it, it's not a contract, but it's essentially a contract. It's the terms and conditions that states and CMS negotiate between each other to in how they're going to operate their programs within their 1115 waiver. And then, or if they have, as I mentioned, if they have an in lieu of service, they have to operate within what is approved within their managed care contracts. So since states can provide nutrition support services under different authorities, they can look very different from state to state. So for example, Oregon has an approved 1115 waiver that prescribes a specific social and clinical criteria required to be eligible for HRSN services. Additionally, their 1115 STCs include attachments for required protocols for HRSN infrastructure and services. Some states, such as Massachusetts, had HRSN-like programs prior to 2022 when the 1115 waiver opportunity was released. So when states like Massachusetts and others that had those types of programs came up for renewal, not currently, but during the time up until present, 2022 to 2025, they were required to come into compliance with the new guidelines, but they were given time to do so, time to ramp down certain things, time to develop new deliverables, that sort of thing. Then you have other states like California, as an example, that developed an in lieu of services program to address HRSN. So they developed that, I believe it was in 2022 when they first started that program. So since the finalization of the 2024 in lieu of services rule, they that, as I mentioned, was a new section in CFR. They have had to make changes to their previously developed programs to come into compliance with those new rules. States were also given some time to make those adjustments, but not as much time as they were given in the 1115 waivers. But even still, the rules and regulations around the flexibility still result in programs looking differently. So one of the biggest examples you'll see is under an 1115 waiver HRSN program, members may receive up to 3 meals a day, while under an ILOS, they can only receive up to 2 meals a day, similar to a traditional HCBS program. And then currently, there are many states that have pending 1115 requests. Maybe they did not have an HRSN program and they had a request pending prior to the new administration coming in. We saw a flurry of those get approved right at the end of the old one into the new, but there are still some that were not. And then there's a lot that are coming up for renewal. I know Oregon's is coming up for renewal in the next couple of years. Other states that have come up for renewal more recently that were really just waiting to see what the administration is going to do with these proposals to give us some insight into the future direction of these programs. I personally feel strongly that although the guidance and parameters may change, the administration is going to continue to support nutrition related services and Medicaid to some degree. We just don't know what it's going to look like and what changes they might make to it. Next slide, please. So with all that being said, as things are evolving in your states, or if you are, I don't know if some of the organizations are in multiple states, some of the biggest things to keep in mind when working with state agencies is one, active involvement during their Medicaid waiver application, amendment, and renewal process. Right, there is a formal public process that is required by CMS, by federal regulations that states must follow. It's very public. They have to have public what are those, public hearings, that sort of thing, and it's very prescribed. So if you're signed up for your register, however the state gives out their information, you can get information that way. Also, there are, for in lieu of services, there's not a prescribed public process, right? States are not required to go out to public comment to have anything to do with their ILS programs. Some states choose to, but they don't have to. So for that sort of thing, you'd want to be sure that you're cued in on any listservs that they have. States may not do a formal process, but they typically will. If they have a listserv for groups for certain things, will send information out that way. So those are two different kind of ways that you have to pay attention to how states are developing their programs and when you can comment and participate and that sort of thing. Also, when working with states, you want to be sure that if you are commenting or some states have a fee-for-service kind of methodology. You're trying to work with them to get into their program. It's important to have data-driven evidence of the benefits of nutrition programs that you have implemented. So if you have meetings with stakeholders, you want to come with that type of information. And this is what we've done, and this is, kind of what supports our work and that sort of thing. Which is also important when partnering with MCOs and in Oregon's case, CCOs. But also it's important to use a collaborative approach when aligning nutrition services with health plan goals, such as, what are their goals? What are they trying to meet? Do they want to improve patient outcomes, reduce hospital admissions? Like, how can we work together to develop a nutrition support program that aligns with the plan's goals? That's especially important in lieu of service that a lot of times may be different plan to plan, the slight differences. And then it's also important to work with them, ensure you have, ongoing joint evaluations and conversations to track program success and make modifications and changes as you go. Some of the key lessons we've learned in working with states is engage early with stakeholders, early dialogue with Medicaid offices, health plans, and community partners. It prevents implementation barriers, helps things go more smoothly. And also flexibility is key. Successful programs will adapt their model to fit various state regulations and stakeholder preferences. That part is, is really important. Also, clear and consistent communication, being sure to align program messaging with state and health plan goals. And then evaluate and evolve regularly. Continuous feedback from partners and beneficiaries ensures program effectiveness and helps to identify and improve areas of improvement and growth in the program. Next slide, please. Next, I'm working with in the federal area. Obviously CMS is going to be huge when it comes to Medicaid. So you want to monitor CMS regulations and guidance around nutrition integration into Medicaid. For example, watch for any upcoming waiver flexibilities and health initiatives that might come out. There's also CMS guidance on social determinants of health screening and standardized quality measures that related to nutrition that have been coming out in proposed rules. You want to watch for any federal level proposed rules that come out around these areas. Sometimes they're, and this goes kind of into the next, federal funding opportunities as well, but sometimes it goes into the weeds and it's hard to kind of find what's in there. But it's really important to just really watch for them coming out, dig in and just determine if there's anything related to quality measures related to nutrition, SDOH, that sort of stuff. And as I mentioned, track potential new rules and regulations, such as the calendar year, the Medicare physician fee schedule, final or proposed rule that's out right now. Although Medicare may not be the program that's providing these services, Medicare and Medicaid are very intertwined. So I would say don't ignore the Medicare rules. You definitely want to take a look at those as well. And then also follow opportunities that are emerging from CMMI, which is the Center for Medicare and Medicaid Innovation. They are doing a lot of revision within there as well as CMS, changing some of their value-based care programs, coming up with new preventative models, discussions around nutrition interventions. So that's another one that you want to pay close attention to. And then lastly, legislation. So monitoring legislation like the Medically Tailored Meals Demonstration Act, which is an older, previous years, but could be something that comes back around. Just watching for what comes out around legislation is also another opportunity to get involved and advocate around these areas. And then lastly, engaging with advocacy coalitions, similar to this, promoting, legislation focused on integrating nutrition and healthcare, all important things and lessons that we've learned that are important to kind of keep track of. And next slide, please. So lastly, kind of to reiterate, but, just clear calls to action. You want to be engaged with your state Medicaid program, submitting written comments, supporting nutrition programs during public feedback periods, building an evidence base, gather stories and data, showcasing improved outcomes and reduce healthcare costs from the nutrition interventions that you have implemented. participate in coalition and advocacy groups with organizations or similar groups that are advocating for food as medicine policies. And then stay important and connected. Follow updates from CMS, policy groups, organizations, and watch for and participate in the rule and regulatory development process. And then last slide. Next slide. Yeah, next slide is the last slide. So yeah, that's it for my our presentation here. I did see a bunch of questions kind of popping up that I was watching out of the side of my eye. So I'm definitely open to answer any of those that you may have.
Thank you so much, Kimberly. I've been tracking those and I can read them out to you if that makes it easier.
Sure.
Cool.
And
So
sorry. And I'm going to
go ahead.
apologize in advance. Not sure. I know we had some of our operational people on early on in the call. Some of the I know that I see Katie's here. So some of these okay. You're still okay. So yeah, I was going to say some of the questions, if they're more operational in nature, may have to lean on some other folks on our team. So
that sounds good. Yeah, I can read these out and then whoever wants to answer them. So the first one is, are in lieu of services approved on a per patient basis, or are they a benefit across the board in a state's Medicaid plan?
So I would say that's a combination. So an in lieu of services program is developed for the state Medicaid program as a whole. However, they are focused on specific eligibility criteria, similar to an 1115. So a state may have an in lieu of services program for pregnant and postpartum mothers that also have a chronic condition that is related to diet, like gestational diabetes or high blood pressure, etc. So if they meet those requirements, then they could qualify for the program.
Thank you. The next question we have is, does an organization need to become a traditional Medicaid provider to receive referrals and bill for meals, medical nutrition therapy, et cetera, via in lieu of services or non-1115 waivers? So some guidance on workflows between service providers and or plans providers would be most welcomed.
Can you repeat that? Sorry, I'm trying to scroll up and see if I can see that one.
That's okay. This one's from Connie, and Connie, feel free to unmute yourself if you want to ask this yourself too. But
yeah, that one was packed.
It's packed. I think so. And Connie, again, stop me if I'm interpreting your question wrong. But in Oregon right now, with the HRSN benefit providers, essentially. The CCOs in Oregon are contracting with those HRSN providers, but that doesn't mean that they have a Medicaid contract. It just means that they're contracted to provide HRSN services. So I think this question is getting at, like, does an organization, if they're providing in lieu of service benefits or in lieu of services, program, programming services, do they need to become a traditional Medicaid contracted provider to take those referrals and to bill for meals for an ILOS program?
So I would say the answer to that depends. So I'll kind of go over a little. Luckily, in my old life, I did my provider enrollment was in our area. So like I said, it depends. So an in lieu of services program they have to be contracted or partnered or whatever the plans required with the plans, as it has to be delivered through managed care. In 1115, it depends if the state is managing that under managed care or if they're doing it via fee for service. And these are not, food as medicine providers are not typical types of providers. So a lot of states don't have the ability to directly enroll some types of providers. There's, requirements. I think it was the CARES Act. I don't remember which one, where states are required to screen even managed care only providers, but Not all states are there yet. So it depends. It's going to depend on what the state says, what the state requires. But I do know for, in lieu of services, you would have to be contracted with a specific CCO in order to get referrals from that CCO to provide services. I hope if that answers your question. If not, if you want to.
And I just want to provide a little extra color too, Kimberly. Hi, everyone. I work with our Oregon partners most of the time, and I encouraged the support of Kimberly and Rebecca for this conversation because some of it is out of my expertise since I'm usually in the community with you all. But outside of Oregon, there's many states where we are enrolled as a Medicaid provider and have to go through all of the, steps to do that. And we do have team members at Mom's Meals who assist with credentialing with the state, with the health plans, standing up billing and all of those requirements. And it is very staff and time intensive, but Oregon's framework is much more there was so much more proactive, collaborative aspects of the program where a lot of those barriers were removed for providers or simply not a part of the program for providers. So even though it can feel, overwhelming, feel grateful that Oregon's framework is certainly more provider friendly than other states.
Thank you, Katie. Yeah.
Thanks, Katie and Kimberly. Yeah, and thank you, Laura. If you are monitoring the chat, Laura Purdue at OHA also provided a link to more information about in lieu of services in Oregon. So if you're curious and digging in deeper on that, Laura's provided a link. Thank you for doing that. Let's see. Oh gosh, now we've, okay, let me scroll up here. We've got, so Becky, also, this is more of a comment, but Becky, you're welcome to unmute, and I'm curious, kind of getting your perspective on this too, Kimberly and Rebecca and Katie. So Becky said, my understanding is that CMS is proposing to remove the 1, hospital commitment to health equity, 2, the screening for social drivers of health measures, and 3, the screen positive rate for social drivers of health measure, beginning with the CY 2024 reporting period and fiscal year 2026 payment determination. There's some chatter back and forth around that. I don't know if you all have any insight to that.
A little bit. So we've been reviewing the rule as well, and that we did see that. From what I was reading, the rules are huge. As far as the SDOH, their reasoning for removing that as like a specific measure or screening is that what they put in the rules, that they feel that that's the sort of information that should be captured within an initial EMN evaluation management visit. That's what they're saying. They are asking though in there what type of measures or quality, like nutrition quality measures, screening measures that people would recommend. So that is one of the more reasons why I say you should review these rules. And if you disagree, definitely comment on them. And even if I would say, don't just comment and say, you shouldn't remove this, this is helpful. I would say, say that and whatever you feel, but then you want to, if they are going to remove it, recommend something to take its place so that you're still having some feedback in what comes out of that if they do remove it. But yeah, you are right. That is in the rule. They're talking about removing that measure and a few other measures.
Great. And I think to your point too, Kimberly, of like, don't just say that's stupid, but offer a different, an alternative. Claire, thanks for putting this in there. Claire mentioned that it is disappointing that those measures will be removed. However, there are other measures in Oregon that are incentivizing or compelling clinical healthcare entities to screen their patients for social needs. They're not connected to these measures. So in Oregon, there are still programs that are moving towards universal social needs screening. And let's see. Okay. And okay, they already did it. Becky's, and it's a rule that they're finalizing it. Thank you. If I missed your question, please feel free to come unmuted or stick it back in the chat. That is what I'm seeing so far. Any other questions or discussion points like this too? It's a lot to sift through.
I think one thing that I'd like to add is hopefully something that helps us all and lift all boats as we kind of get closer to that renewal in a couple years here in Oregon is the kind of invaluable nature of recording, like implementing ways to record patient outcomes as soon as you're up and running. It is so challenging. We have not cracked the code on that either by no stretch of the imagination. But every single time, there's budget constraints or anything that leads to a little hesitation at any level of these programs, it's so important to come to those strategic conversations with data, with member stories, and a lot of the basically concrete information that is very difficult to capture, but is so valuable because of that. So that's just a little, I don't know, seed to plant in all of us, including here at Mom's Meals, because it's challenging, it's not easy, but it's more valuable than anything else we can do to keep these programs going, essentially.
And Katie, talking about keeping those programs going, can you share a little bit more about what y'all are doing here in Oregon with HRSN or in general? I think folks are interested in what does your programming look like in Oregon? Maybe how many different CCOs you might be contracted with. What do those services look like? Yeah, just maybe a little bit of an overview of what you're doing already.
Yeah, absolutely. You might be able to help me fill in the gaps here, Kaylee. Kaylee's becoming a Mom's Meals expert too. So we're partnered with a couple of CCOs across the state, mostly as a medically tailored meal provider. We hope to participate in the fruit and vegetable benefit next year. We'll see how the rates kind of pan out from the state because they don't seem to include what it costs to ship food to a member, which, is very important when it comes to equity, reaching vulnerable addresses, things of that nature. But for now, be a medically tailored meal provider under the HRSN program, and really working closely with the CCOs to, walk through the workflows, identify areas where, maybe we can coordinate outreach in the community to various groups, things of that nature, because awareness is very, very low across the state right now for medically tailored meals. And so one of my main focuses for the next couple of months is to help lift up that awareness in the community, because we might have these phenomenal, really one of the most robust benefits in the whole country is here in Oregon, but there's nobody in the program. So we need to help lift awareness to keep it going. And for example, I was in Portland last month doing some outreach, and every single healthcare provider I met with had never heard of the medically tailored meal program. So just a whole lot of opportunity for us to connect, patients who are in need with providers who understand what this program is, how to refer, and why it will be beneficial for their members. So just a little overview of what we're working on, but we're, like Kimberly mentioned, medically tailored meals is our specialty. We've been doing it for 25 years, so that is the easy part. The hard part is, operationalizing new programs and lifting awareness in communities so those programs are used. But thanks for letting us join the call today so we can share a little bit and also share the amazing work of Kimberly and Rebecca and the rest of our GA team who work tirelessly to make sure that food as medicine is, in every state office across the country.
Thank you so much, Katie. Yeah, and Rose, so we're recording this presentation today. We'll also, Mom's Meals team has graciously allowed us to share this PowerPoint. So all of those amazing terms and vocabulary there, and understanding how Medicaid functions and the 1115 waivers and all of those things, you'll have access to that if you're on our listserv. You can reach out to us and you can help spread the word that way too. If you're interested more in the Oregon 1115 waiver and the health related social needs or HRSN nutrition benefits specific to Oregon, we can also drop a link in there as well. Yeah, thank you so much. And I'm typing this out. I'm handing facilitation back over to Claire. I have another meeting that I have to hop onto at 10 o'clock, but thank you so much to Mom's Meals too. We can continue the questions and discussion here, and realizing if folks need to hop off at 10 too, you're welcome to do that as well.
Thanks for facilitating, Kaylee. Yeah, we do have another 30 minutes, but we can always, give everyone time back in your morning. Does anyone else have questions? You can feel free to raise a hand or come off mute. I might give folks a minute, and if not, then I'll move to our wrap up. Okay, it looks like folks had all their questions answered. So that's great.
Actually, I'm so sorry. May I ask one quick question? I apologize. So for those who are already engaged in medically tailored meals provision, will there be a program to bill for it, like in the future? Like in terms of, Medicaid or Medicare?
I'm sorry.
Like after the current waiver demonstration ends in Oregon?
Mm-hmm.
It's a good question. Yeah, Mom's Meals team, do you have any insight or thoughts on that? Or
I missed part of it. Can you?
Sure. So if you are a current medically tailored meals provider and you're billing Medicaid and or Medicare for it, at the end of this waiver, will there be a program still in existence to bill for it?
So I think what's going to be telling is there are some states that have their waivers like much more closely, like theirs should be renewed any day now. For these programs, I think that's going to be telling what future programs are going to look like. I think it's going to depend on, Oregon's going to have decisions to make. What does CMS support? Because the thing about 1115 waivers, though it's not that the whole waiver won't be renewed, it just may change the structure of how it's laid out. And, if there is, the program is removed from the waiver, the state could opt to do an envelope service kind of opportunity. There were some questions in this final rule about a Medicare medically tailored meals program. I mean, if that were to happen, it's years out, but that is another thing to look at and respond to. So I think it's gonna take. We just gotta watch and see. Unfortunately, is what it comes down to. I don't think it's gonna go away entirely. The structure of it may change. And it's just going to depend on CMS and what they want to approve moving forward.
Okay, thank you. I think that's what's making it so challenging is trying to budget or forecast, but you can't if you don't know it's coming. So thank you so much.
Yeah, you're welcome. I would say if you're not on the CMS listserv, there is a way you can sign up for lots of different things, but you can also sign up to receive notification when 1115 waivers are approved. or states putting out for theirs. Like this is the federal public comment process, but it'll give you like you'll start to see what's approved, and you can open it if it's a state that has an HRSN service, you know, because something's going to happen before Oregon's comes up. There's like a year and a half left. Other states have to have their waivers renewed at some point. So I would say watch for those. That's what we're planning to do, and what we, you know, have been keeping our eyes on. They just there haven't been any yet that have been renewed.
Okay, so sorry to like take up time, but like, so that like, if you just go to CMS and look for something, it'll be like a listserv, because that's really helpful. I'll get on that.
CMS.gov has one and Medicaid.gov has one. I would look at both of them. Medicaid.gov is going to be the one that you can sign up for like waiver notices of states. But CMS.gov has good stuff too. So I would go on there and sign up for both of them. And you can pick like options, what you want to receive information about.
Yeah. Okay, that's so helpful. I really appreciate it. Thank you.
Yeah, no problem.
I had a question. I stepped out for a couple minutes, so forgive me if you touched on this, but can you share anything about where you source your food from and who you work with on that, and whether you have any ability in since you're working across so many different states, like whether you have an ability to work with local producers or like kind of source things differently depending on where you are?
I know enough to be dangerous. Katie dropped who knows way more info, but we do source food from different areas, and we try to, you know, you can't in every state necessarily, but we do source from different areas. We try to source more locally. The fruits and like especially like, you know, fruits and veggies that are in season in that area. So we do source from different areas throughout. Some states we may be able to source more versus others. And then we also have different kitchens throughout the US, and then different facilities, storage facilities. Couldn't come up with the word throughout, so that we in areas that are more heavily populated, where we have more infrastructure, you know, we do a lot of our own deliveries, but we also work with USPS, you know, different delivery mechanisms. Here we go, to deliver for us in places where we maybe don't have as much of a volume or infrastructure yet. So I probably didn't directly answer your question, but but we do source from different areas, and are constantly trying to ensure that when we're working in different states or regions, that we try and source locally and support the local economies in those areas as much as possible.
Thank you. Appreciate it.
You're welcome.
Any other lingering questions? Kimberly, I see that.
I was gonna say, if anything comes up, you know, you guys have our email. I'm not, you know, don't hesitate to reach out after if anybody has questions, if you want to send them our way.
Thanks so much. That's exactly what I was going to ask, is that you provided your emails. Is it okay if folks reach out with questions?
Yep, sure.
Awesome. All right, well, I'll move us on, but yeah, thank you again, Kimberly and Rebecca and all the other folks who I think have probably dropped off the call by now, but from Mom's Meals. This is really helpful and useful to see your kind of nationwide approach. So this is my only wrap-up slide. Just our next working group quarterly meeting is on October 7th. I'm not able to split screen on my current laptop that I'm using this morning, so we will send that registration link out with the follow-up email. Everyone will get that who's on the VeggieRx Google group listserv. So we hope to see you then, and all of the other follow-up materials will be in that email too. Thanks, everyone.